Завершить трансляцию. Так и должно быть написано.
Да, это все.
Good day. Our lecture, Pyodermas and Scabies. Pyodermas and Scabies. Etiology and pathogenesis Pyodermas. Etiology and pathogenesis Pyodermas. Pyodermas are skin lesions. Pyodermas are skin lesions characterized by presence of pus. Димочка, это я с третьей аудитории. А вот смотрите, тут вообще никто не появляется вот рядом. Никто они меня слышат. Вот вообще темный экран. Да? Ну вот вообще никого. Вот гляньте. Вот никого нет. Ни одной души.
Ну, трансляция открыта, все работает.
А где же
6 человек есть.
Есть? А что же они не пишут?
А вы можете им сказать, чтобы они писали.
Сказать.
Ну, это же иностранцы, они вовремя-то не приходят.
Ну, хорошо, все, слышись, есть хорошо, продолжаем. Pyodermas are skin lesions characterized by presence of pus. Various species of Staphylococcus and Streptococcus are most common causative agent of pyoderma. The disease may also be caused by the blue pus bacillus, Proteus vulgaris, Escherichia coli, fungi, pneumococcus, and many other microorganisms. Pyodermas are skin lesions characterized by presence of pus. Various species of Staphylococcus and Streptococcus and most common causative agents of pyoderma. The disease may also be caused by the blue pus bacillus, Proteus vulgaris, Escherichia coli, fungi, pneumococcus, and many other microorganisms. The contributing factors: superficial skin injuries, microtraumas such as cuts, excoriation, scratch, superficial burns, soiling of the skin, occupational soiling with coal, lime, cement, and soiling because of faulty hygienic care. Our cooling or our heating of the body. The endogenic factors are just as diverse, not should be made of disorders of carbohydrate metabolism, endocrine disorders, functional disorders of nervous system, hypervitaminosis, acute chronic disease, and hereditary factors weakening of immune defense mechanism. Contributing factor: superficial skin injuries, soldering of the skin, overcooling or overheating of the body. Classification: Pyodermas. Pyodermas are classified by several items. By etiology, staphylococcal, streptococcal, mixed. By etiology, staphylococcal, streptococcal, mixed. By depth of the localization, superficial, deep, By time of appearance of the lesions, acute, chronic, according to the cause of disease, primary, secondary. Staphylococcal pyodermas. The process develops predominantly in the regions of the hair follicle and in the sweat and sebaceous glands. The pustule are conic or semispherical. Their walls are thick and tensed, and the pus in thick and yellowish green. Downy hair is often found in the center of the pustule. Only in children, staphylococcal cause the development of superficial bulla or blister, which are not connected with the sebaceous hair follicles of the sweat glands. The staphylococcal pyodermas process developed predominantly in the regions of the hair follicles and in the sweat and sebaceous glands. The pustule are conic or semispherical. Their walls are thick and dense, as the pus in the thick and yellowish green. Downy hair is often found in the center of the pustule. Only in children, staphylococcal cause the development of superficial bulla, which are not connected with the sebaceous hair follicles or the sweat glands. Staphylococcal pyodermas subdivided: osteofolliculitis, Burkhart's impetigo, Burkhart's, folliculitis, psychosis, furuncle, carbuncle, hidradenitis, osteofolliculitis, psychosis, furuncle, carbuncle, hidradenitis. Osteofolliculitis, impetigo, Burkhart's. Staphylococcal impetigo is included in the superficial staphyloderma. Osteofolliculitis or staphylococcal impetigo is included in the superficial staphyloderma. This is an acute inflammatory follicular pustule. Situated at the orifice of hair follicle. Osteofolliculitis is marked by the formation of a bulla in the epithelium of the orifice of hair follicle directly under the onion layer. This is acute inflammatory follicular pustule situated at the orifice of hair follicle. Osteofolliculitis is marked by the formation of a bulla in the epithelium of the orifice of hair follicle directly under the onion layer. Folliculitis. In the deep folliculitis, the pathogenic staphylococcal penetrate the follicle deeper than they do in osteofolliculitis and cause inflammation of the greater part of the whole follicle. Painful red nodules appear at the first, which later transform into pustula, with the fine hair. In a few days, the secretion of the pustula dry into a crust of separation, advances and necrosis of the connective tissue occurs. If the disease follows the ordinary course, small punctate scar form in 5 to 6 days at the site of deep folliculitis. Isolated lesions of deep folliculitis are usually found of the scalp and back of neck, so versatile localization is possible. In deep folliculitis, the pathogenic staphylococca penetrate the follicle deeper than they do in osteofolliculitis and cause inflammations of the greater part of the whole follicle. Painful red nodules appear at first, which later transform into pustule, pierced with fine hair. In a few days, the secretion of the pustule dry into a crust of separation, advances, the necrosis of the connective tissue occurs. If the disease follows the ordinary course, small punctate scar form in 5 to 6 days at the site of the deep folliculitis. Isolated lesions of deep folliculitis are usually found of the scalp and back of the neck, so a versatile localization is possible. Psychosis. Staphylogenic psychosis is a chronic relapsing infection of hair follicles. Males are infected more often. Chronic relapsing infection of hair follicles. At the onset of the disease, a few lesions of osteofolliculitis appear on a relatively circumscribed skin area, which tend to spread to larger and larger areas. An inflammatory infiltrate forms around the lesions, as a result of which the affected area thickens and turns bluish red and is sometimes painful. Involvement of new follicles in the process lead to slow growth of the focus of affection, in which there may be a large number of inflamed follicular orifice formation and conglomerate of pustules. After the top of pustules open, the pus dries up into dirty yellow crust which stick to the hairs. Inflammatory infiltrate form around the lesions, as a result of which the affected area thickness as it turns bluish red, is sometimes painful. Involvement of new follicle in the process lead to slow growth of the focus of affection, in which there may be large number of inflamed follicular orifice forming a conglomerate of pustules. After the top of pustules open, the pus dries up into dirty yellow crust which stick to the hairs. Psychosis. A hair shaft removed from the focus has a gelatin-like mouth around its root. This is the epithelial hair sheath Saturated with pus, psychosis vulgaris is usually a persistent condition remaining for years, which exacerbates now and again and has a depressing effect of the patient's mental condition, especially if it is localized on the face. In some cases, there are no subjective disorders. In others, the lesions are attended with sensation of burning, mild itching, or pricking. Differential diagnosis is made with infiltrative separative trichophytosis, parasitic psychosis, which is characterized by a more acute cause, the formation of thick and deeper seed nodules. Furuncle or furuncle. The following three stages in the development of furuncle are distinguished. The stage of the development of the infiltrate. Second stage of separation area necrosis, and third stage of healing. First stage of development of infiltrate, you can see picture number 1. The stage of separation area necrosis, picture number 2, and stage of healing, picture number 3. Furuncle, hard elevated bright red infiltrate, first form around the hair follicle. The infiltrate is not shape-like circumscribed. It is attended with a pricking sensation or mild pain. The infiltrate acquires gradually the form of a firm tumor which grows along the periphery and becomes more painful. There is swelling of the surrounding tissue. The swelling in the region of the cheek, eyes, lips may be shape-like pronounced. The second stage, set in 1, the 3rd or 4th day, the furuncle grows to 1 cm in diameter and a pionecrotic core with pustule of its surface form in the centers. Furuncle, hard elevated bright red infiltrate, first form around the hair follicles. The infiltrate is not shape-like circumscribed and is attended with a pricking sensation or mild pain. The infiltrate acquires gradually the form of firm tumor which grows along the periphery and becomes more painful. There is swelling of the surrounding tissues. The swelling in the region of cheek, eyelids and lips may be shape-like pronounced. The second stage sets in on the 3rd or 4th day. The furuncle grows to 3 cm in diameter and a pionecrotic core with pustule of its surface form in the center. The furuncle takes the shape of conic tumor with smooth, loosely blue skin. The pain is very severe in the period. Body temperature may rise to 37, 38, and symptoms of toxicosis may develop general indisposition, malaise, headache. The top of pustule opens spontaneously or is opened artificially and pass sometimes with admixture of blood is discharged from the furuncle, after which a yellowish-green necrotic plug, necrotic core, comes out. After removal or rejection of the core, swelling, infiltration, and pain subside, and the remaining crater of the furuncle is filled with granulation, which are replaced by a scar in 2 to 3 days. The scar is bluish red at the first, then gradually turns white and is sometimes hardly visible. The developmental cycle of furuncle commonly lasts 8 to 10 days. After removal of rejection of the core, swelling, infiltration, and pain subside, and the remaining crater of the furuncle is filled with granulation, which are replaced by a scar in 2 to 3 years. The scar is bluish red at first, then gradually turns white and is sometimes hardly visible. The developmental cycle of furuncle commonly lasts 8 to 10 days. Furunculosis is a condition in which there is recurrent eruption of furunculosis. Furunculosis may be localized on a circumscribed skin area or diffuse, disseminated. According to the cause, furunculosis may be only chronic, a small number of furuncles appearing and short intervals of uninterruptedly for months. Furunculosis is condition in which there is recurrent eruption of furunculosis. Furunculosis may be localized on a circumscribed skin area or diffuse, disseminated. According to the cause, furunculosis may be only chronic, a small number of the furunculosis appearing and short intervals of uninterruptedly for months. Treatment depends on the stage of the pathological process. In stage on infiltration, physiotherapy is placed. In stage of separation area necrosis, ichthyol rod is placed. In stage of healing after opening, dressing with hypertonic solution is put on and keratoplastic unguentum or ointment is used. In stage infiltration, physiotherapy is placed. In stage of separation area necrosis, ichthyol rod is placed. In stage of healing after opening, dressing with hypertonic solution is put on and keratoplastic ointment is used. Carbuncle is a bilious purulent necrotic inflammation of deep layers of dermis and hypodermis with the inclusion of some near-boring follicles. Pathogenesis and treatment resembles that of furunculosis. During extensive infection, surgical intervention is recommended. Carbuncle is 2 or more furuncle on common basement. Gyntraadenitis is a purulent inflammation of apocrine sweat glands. The main role in pathogenesis is played by general weakness of the organism. Increased sweating, deviation of sweat reaction towards the basic side, microtraumas, endocrine disorders, endocrinopathy. At the onset of the disease, solitary small heart mount-like nodes are palpated as the thickness of the dermis of hypoderm. The patient experiences mild itching or pain at this time. The nodes grow rapidly in the size, adhere to the skin, become pear-shaped and protrude like nipples, and resemble each other. The nodes grow rapidly in size, adhere to the skin, become pear-shaped and protrude like nipples, and resemble each other. The skin turns bluish red, swelling of the tissues develop, and the painfulness increases considerably. The isolated nodes often coalesce, soften, and fluctuation appear, after which they open spontaneously, and this pass with an admixture of blood is discharged. No necrotic core forms. The skin turns bluish red, swelling of the tissues develops, and the painfulness increases considerably. The isolated nodes often coalesce, soften, and fluctuation appear, after which they open spontaneously, and the pass with an admixture of blood is discharged. No necrotic core forms. A diffused hard disc-like infiltrate resembling a phlegmon forms sometimes, in which case pain is felt not only during movements but at rest too, and disables the patient. Diffuse hard disc-like infiltrate resembling phlegmon forms sometimes, in which case pain is felt not only during movements but at rest too, and disables the patient. Maturation of the lesions is attended as a rule with indisposition, moderately elevated temperature, and marked painfuls. Maturation of the lesions is attended as a rule with indisposition, moderately elevated temperature, and marked painfulness. After the nodes open, the sensation of scratching and pain subside and ulcers heal in the few days. After the nodes open, the sensation of scratching and pain subside and the ulcer heal in few days. Resolution of the infiltrate takes longer. Recurrences are frequent. however, enhance the process and protract cause. Recurrence are frequent, however, enhance the process and protract cause. Axillary hidradenitis is usually unilateral. Axillary hidradenitis is usually unilateral through bilateral lesions, are also encountered. The average duration of hidradenitis is 10 to 15 days, but a protracted recurrent course is observed quite often. Particularly in obese individuals, in patients with hyperhidrosis, diabetes, and in persons who pay little attention to skin hygiene. Particularly obese individuals, in patients with hyperhidrosis, diabetes, and in persons who pay little attention to skin hygiene. Staphylococcal pyodermitis has the following characteristic sign. Streptococcal infect mainly smooth skin. Streptoderma as a rule has a surface character. The primary elements is a flaccid vesicles. Flictena tends to grow on periphery, with transparent contents. Children and women with soft skin get infected frequently. Streptococcal pyodermas. Impetigo bullosa, fissural impetigo, impetigo cercinata, intertriginous streptoderma, simple streptoderma, simple lichen, eczema. Streptococcal impetigo subdivided. Streptococcal impetigo bullosa, fissural impetigo cercinata, intertriginous streptoderma, simple lichen, and eczema. Streptococcal impetigo is a surface non-follicular pustule on hyperemic edematous base. Flictena is a surface non-follicular pustule on a hyperemic edematous base. Flictena. In pathogenesis, important role is played by maceration and mechanical destruction of the epidermis. Important role is played by maceration and mechanical destruction of the epidermis. The cycle of development of the disease takes 3-4 weeks. Takes 3-4 weeks. Highly contagious. The disease begins with the appearance of a small red spot. The disease begins with the appearance of a small red spot on the surface of which a vesicle of the size and penhead to a lentil flectena forms in a few hours. The disease begins with the appearance of a small red spot on the surface of which a vesicle of the size of penhead to a lentil flectena forms in a few hours. In some cases, the flectena forms of visible normal skin. The tensed vesicle turn flabby within a very short time, and the clear secretions become purulent, thick, and sometimes hemorrhagic, and then dry into thin grey crust, which gradually falling out. The tensed vesicles turn flabby within a very short time, and their clear secretions become purulent and sometimes hemorrhagic, and they dry into thin grey crust, which is gradually falling out. Impetigo cercenata. The flectena are usually separated from each other by healthy skin, by that also may spread to the periphery, and they coalesce to form annular lesions. Impetigo cercenata. The flectena are usually separated from each other by healthy skin, but they also may spread to the periphery and coalesce to form annular lesions. Impetigo cercenata. The average duration of the disease is 3 to 4 weeks. The average duration of the disease is 3 to 4 weeks. A transient bluish-pink spots. A transient bluish-pink spot is left after the crust falls out. A transient bluish-pink spot is left after the crust falls out. They are neither scar nor atrophy of the skin. They are neither scar nor atrophy of the skin. The predominant localization of the process is the face and the side of the trunk and lips. The disease may spread rapidly due to all child contact, and the name impetigo contagiosa. It's impetigo cercenata. Impetigo bullosa. The second type of impetigo is bullous impetigo, characterized by rapid progression of vesicles to flaky large bulla. The second type of impetigo is bullous impetigo, characterized by rapid progression of vesicles to flaky large bulla. The bulla eventually rupture and form thin, light brown crust. The bulla eventually rupture and form thin, light brown crust. Fissural impetigo. Angular stomatitis or perlage is conditional marked by a rapidly rupturing flectena is one of the both angles of the nose. Areas at the wings of the nostrils and lateral margin of the palpebral fissura may also be involved in the process. areas at the angles of nostrils and lateral margins of the palpebral fissura may also be involved in the process. Flabby vesicles form at first in the ankles and the mouth, which rupture and expose superficial linear slit-like fissures. The formed on a yellowish crust drop off because of maceration. Visceral impetigo disease is attended with a sensation of itching, salivation, pain during eating. It takes a prolonged course in dental caries. Rhinitis, conjunctivitis in persons who have a habit of licking the ankles. It takes a prolonged course in dental caries, rhinitis, conjunctivitis in persons who have a habit of licking the ankles of the mouth. That is why disease occurs mostly in children. In elderly individuals with nudges, and persons who diet lacks vitamin B complex. Tourniol, one of kind of visceral impetigo, is mostly encountered in adults. Flectena form around the fingernails, first with serious secretions, which later become clotly purulent. The disease develops in wounding of the fingers and nails, which creates condition from the entry of streptococcal. The disease develops is wounding of the fingers and nails, which creates condition from the entry of streptococcal. The affected phalanx swells is painful. After the flectena ruptures and erosion from embracing the nail plate like horseshoe. The process may terminate in the loss of the nail plate. Lymphangitis Achille indisposition and fever are sometimes encountered. Simple streptoderma. Simple streptoderma is considered to be a dry variety of impetigo streptogenesis. It is particularly widespread in children and is characterized by red or oval, strictly circumscribed, whitish or pink foci, which are abundantly covered with small scales. The foci are especially conspicuous in individuals with pigmented skin. The disease may be cured by exposure to sun rays by the affected areas and then weekly, so that mottling of the skin surface occurs. The favorite localization is the skin around the mouth, the cheeks and the regions of the lower jaw. Sometimes the lesions occur of the skin of the trunk and limbs. The disease usually occurs in spring or autumn. In children's collectives, Pityriasis simplex may acquire the character of epidemic. The disease usually occurs in spring or autumn. In children's collectives, Pityriasis simplex may acquire the character of epidemics. There is sometimes a sensation of mild itching. Intertriginous streptoderma. The disease occurs on contiguous skin surface under the breast, in the folds of the abdomen, in obese persons, behind the ears, in the inguinofemoral and intergluteal folds, in the axilla. It develops predominantly in our feet, obese, sweating children of those suffering from exudative disease and diabetes. The primary lesions is inflictena, the size of a millet or lentil. Very many inflictena erupt, coalesce, and burst rapidly, leaving continuous erosive, weakened bright rose surface with scalloped boundaries and a border or peeling epidermis of the periphery. Sitting or separately arranged pustular lesions in various stages of development are seen next to the main foci of affection. Painful fissures are often found deep in the folds. The disease fold, a protracted cause with marked subjective disorders. In intertriginous lesions or waste origin in the contents of the bulla, as the crust do not have a yellow hue and elements of waste-like fungi are discovered in the scabs of epidermis on the periphery of the main foci of in the setting. Eczema vulgaris. Eczema is a chronic streptococcal disease. Eczema initially presents as a vesicles or vesicular pustule on the lower extremities. Eczema initially presents and vesicles or the vesicular pustules on the lower extremities of the children or negligent elderly patient. The skin lesions gradually enlarge to form an ulcer with punched out appearance. Eczema initially presents as the vesicles or vesicular pustule on the lower extremities of children of neglected elderly patient. The skin lesions gradually enlarge to form an ulcer which punch out appearance. Mixed streptostaphylococcus pyodermitis. Classification. Impetigo vulgaris. Epidemic pemphigus of newborn. Epidemic pemphigus of newborn. Chancreform pyoderma. Chancreform pyoderma. Chronic ulcerous and ulcerovegetative pyoderma. Chronic ulcerous and ulcerovegetative pyoderma. And granuloma pyogenicum. Obotriomycoma. Granuloma pyogenicum. Obotriomycoma. Impetigo vulgaris or streptostaphylococcal impetigo. Not only pathogen itself, but also traumas, maceration, and lotus skin of the importance in pathogenesis. Starts with the formation of flictena, after which contents become translucent as a result of joining of staphylococcal infection. They dry up into a yellowish-green crust, mostly on the face in youth and women. The cycle of development of the disease takes 8-15 days. Treatment: aniline salts, creams with antiseptics. Impetigo vulgaris. Impetigo vulgaris. Epidemic pemphigus of the newborn. Epidemic pemphigus of the newborn. It is an acute contagious disease of staphylococcal nature. Pathogenesis. The main pathogenic factor is sensitivity or the skin the infection, prematurity, pregnancy, toxicosis, birth injury. The source of infection is often the medical staff, mother and patients themselves. Clinical feature. Emergence of small vesicles with intense cover and serious yellow contents, tendency towards fusion, or formation of large vesicle. Fever is possible. Vesicles are converted into pustules, open, erosion, slowly epithelialized. It is necessary to differentiate epidemic pemphigus from syphilitic pemphigus. The latent areas of the palms and soles on an infiltrated base, characterized by the presence of Treponema pallidum in the contents of the vesicles. Positive complement fixation test in child and mother. The later irises of the palm and soles on an infiltrated base characterized by the presence of Treponema pallidum in the contents of the vesicles. Positive complement fixation test in child and mothers. Treatment: antibiotics, antistaphylococcal serum, transfusion of plasma, locally aniline stains, creams with antibodies. Chancreform pyoderma. It is rounded erosion or ulcer with torus-shaped borders and infiltrate base, mostly single, not very painful, sometimes accompanied by enlargement of regional lymph nodes. It is rounded erosion or ulcer with torus-shaped borders and infiltrate base, mostly single, not very painful, sometimes accompanied by enlargement of regional lymph nodes. In distinction from chancre, there is no treponema pallidum. Serological reaction is negative. Infiltrate basically comes out far away from the erosion, and also it should not be treated before the confirmation of the diagnosis. After the exclusion of syphilis, treat like other pyodermas. It should not be treated before the confirmation of the diagnosis. After the exclusion of syphilis, treat like other pyodermas. Chronic ulcerous and ulcerovegetative pyoderma. In pathogenesis, an important role is played by hyperresistance of the organism and weak properties of the pathogen, which leads to the decrease of the reaction of the organism to penetration of pyococ. The primary pustules undergo necrosis, form ulcer with a loose base and flaky gray granulation. The process slowly enlarges and deepens and converts into chronic lasting for months and years. The primary pustules undergo necrosis from ulcer with loose base of flaky gray granulation. The process slowly enlarges and deepens and converts into chronic lasting for months and years. Chronic ulcerous and ulcerovegetative pyoderma. Differential diagnosis should be made from warty ulcerous and ulcerovegetative tuberculosis, tertiary syphilis, and deep mycosis. Tertiary syphilis and deep mycosis. Tertiary syphilis and deep mycosis. During of the skin, the inflammatory reaction is less dominant. Skin tuberculin test is positive. During tertiary syphilis, characteristic feature in copper red color and dense consistency, absence of tendency towards fusion. Positive immobilization reaction of treponema pallidum. Positive not only immobilization reaction and serological blood test positive. Deep mycosis is differentiated through bacteriological and cultural diagnosis. Treatment. All of the superficial and acute pyodermas are to be treated by aniline dyes. All the superficial and acute pyodermas are to be treated by aniline dyes. Deep and chronic pyodermas may be treated by antibiotics and immune modulators such as specific immune modulators, immunoglobulins, non-specific immune modulators, many other medicines. Scabies. Next disease, parasitological disease, scabies. Scabies is a skin infection caused by itchy little mite. Scabies is a skin infection caused by itchy little mite called Sarcoptes scabia. The mite makes tiny little burrows in the skin. The mite makes tiny little burrows in the skin and often announced at first. After a few weeks, you develop an allergic reaction to the waste product produced by the mite. After a few weeks, you develop an allergic reaction to the waste product produced by the mite. An itchy allergic rash develops which looks very much like eczema. An itchy allergic rash develops which looks very much like eczema. This disease often occurs in autumn and spring season. Incubation period is from 7 days to 1 month. Transmission is through direct or indirect contact. At the place of the mite's penetration, the appearance a vesicle, which is accompanied by intense itching, particularly at night, when the female mite makes new passage in the epidermis. Characteristic location of the vesicles is paired entrance and exit. Entrance and exit. Sometimes they're joined, gray passage from 2-3 mm till 0.5 cm. Localization in the adults. Fold of hands, wrist, extensor surface of the forearm, abdomen, mammary glands, umbilical region, localization in children, on the face, head, palms and soles. Localization in adults, folds of hand, side surface of the fingers of the hand, wrist, extensor surface of the forearm, abdomen, mammary glands, umbilical region. Localization children on the face, head, palm and soles. Treatment. Different antiparasitic drugs. 20% emulsion benzyl benzoates. For children, 10% Demyanovich method, 20-30% sulfur ointment, Wilkinson ointment, soap key, 5% emulsion, Spregal, sulfate, and Spregal, sulfate and Spregal. Prophylaxis. Before starting the treatment and after 8 hot shower, change of clothes. Prophylaxis, simultaneous treatment of all the patient at the place of infection, examination of families and children where it was found through disinfection of bedding. Through disinfection of bedding. Next lecture, eczema. Start our lecture. Да. Ой, да, девочка, это я с третьей аудитории, представить мне можно, да? Ага. Start our lecture, eczema. And next lecture continue. Сейчас я... Вот спасибо. Я вот тут вот не знаю, что-то не то, да?
Все правильно.
Все правильно. Так, если бы я сама... Ага, вот туда и все. Я так вот на половине где-то минут 20 закончу и оставлю, а потом продолжу. Ага, все, спасибо. Пошло, да?
Да.
Угу. Они сидят еще тут,
да?
Next lecture, eczema, etiology and pathogenesis eczema. It is necessary to comprehend that eczema is polyetiological disease with complex pathogenesis, where the main role is played by allergic factors affecting the organism with change reactivity of central and vegetative nervous systems. The autoallergic phenomenon is of certain significance, which is due to the presence of focal infection, visceral and endocrinopathy, immune condition. Eczema starts with the formation of monovalent sensitization, increased sensitivity towards a certain allergen, which afterwards may transfer into polyvalent sensitization. Etiology and pathogenesis. Polyvalent sensitization. Pathogenic types of eczema: true eczema, microbial eczema, microbial eczema. Microbial eczema include nummular eczema, varicose eczema, post-traumatic eczema, seborrheic eczema, infantile eczema. Infantile eczema, it's now we call atopic eczema. Atopic eczema. Classification of dermatitis. Simple dermatitis, physical, mechanical, chemical, biological, and allergic dermatitis, simple dermatitis, physical, mechanical, chemical, biological, allergic dermatitis. Terminology. Eczema, used as a clinical descriptive term, it describes a process that is clearly superficial in form and that early is erythematous papular vesicular, oozing and crusting, and later red-purple, scaly, lichenificate and possibly pigmented epithelial disruption and non-sharp margins are its characteristic. Epithelial disruption and non-sharp margins are its characteristic. True eczema. The main role in pathogenesis is played by a polyvalent sensitization and pronounced neurogenic disturbances. Clinical features: disseminated, symmetric and blunt borders of the lesions, intense itching, primary lesions is a punctulate microvesicles, serous wells, crust with small foci, fine laminar desquamation. Clinical features: true eczema, disseminated, symmetrical and blunt borders of the lesions, intense itching, primary lesions is punctulate microvesicle, serous wells, crust with small foci, fine laminar desquamation. First appear erythema, eczema erythematosum, against the background of which microvesicles, the size up of a pinhead, papules mostly exudative, and pustules are formed eczema vesiculosum, papular vesiculosum, papulosum, and pustulosum. Microvesicles in the center of focus rupture, the serous exudate seeps onto the skin surface and produces oozing areas with a macerated and scaling oily layer. Eczema meditans, careful examination of the focus will reveal numerous points, erosion from which small drops of serous exudate emerge, serous wells. Stage morphological lesions, symptoms eczema: acute, vesicles, blister, intense red, intense itch, staining, burning. Subacute: red, scale, fissuring, patch appearance, scalded appearance, slight to the moderate itch, staining, burning. Subacute: red scale, fissuring, patch appearance, scalded appearance, slight to the moderate itch, staining, burning. Chronic stage: thickened skin, lichenificate excoriation, fissuring moderate to intense itch. Chronic thickened skin, lichenificate excoriation, fissuring moderate to skin itch. Dyshidrotic eczema is a deep vesicular skin reaction involving the fingers, the interdigital space and feet. The vesicles have a characteristic morphological appearance as that of the sago grains. The condition is rare in young age groups and more common in adults. Pruritus is common. Sometimes lesions can be painful or it may be asymptomatic. Scratching of vesicles leads to weeping and crusting. Microbial eczema, microorganisms or their product that clear when the organisms are eradicated may cause microbial eczema. This should be distinguished from infected eczema, in which eczema is complicated by secondary bacterial or viral invasion of the broken skin. The skin becomes sensitive to bacterial product of chemical presence in the exudates. Infection eczematoid dermatitis is considered as example of autosensitization. The mechanism by which microorganisms can cause eczema is not understood. Bacterial antigens can promote a cytotoxic reaction in the skin. The mechanism by which microorganisms can cause eczema is not understood. Bacterial antigens can promote cytotoxin reaction in the skin. Clinical feature: the distinction between infective and infective eczema is difficult. Infected eczema shows erythema with exudation and crusting. The exudation may be profuse with crusting or slight with the accumulation of layers of somewhat greasy moist scale below the surface is rare and red. The margin is characteristically shape-like defined. There may be small pustules and fissura in advancing age. Infective eczema usually presents as an area on advancing erythema, sometimes with microvesicle. It's seen predominantly around discharging wounds of ulcer or moist skin lesions of other types. Infective dermatitis is relatively common in patients with venous leg ulcers, but care must be taken. The distinguished is from contact dermatitis due to topical preparations. Varicose form. Acute inflammation is characterized by a red, superficial itchy plaque with weeping and crusting on the lower limbs, especially the medial side of lower legs, ankles and calves. This is due to combination of eczematous change and cellulitis. A vesicular eruption and reaction of the palms, trunks, extremities sometimes accompanies the acute inflammation. In subacute and chronic stage, an increased hydrostatic pressure leads to the extravasation of red blood cells from the leg vein. Disintegration of these red blood cells leads to hemosiderin deposition. The skin looks dry, scaly, hyperpigmented, and accompanied with white atrophic change, atrophic blanch. Ulceration is common. It's the late stage and its serious consequences. Microbial eczema, nummular form. Nummular dermatitis, chronic eczematous lesions that is caused by different known and unknown factors. The condition may be preceded by atopic dermatitis. The lesion may appear as separate entity as annular, coin-like of discount lesions of the extensor surface of extremities, trunk, and buttocks. Nummular eczema, discount eczema, is characterized by circular or oval plaques of eczema with clearly demarcated margin. The typical lesions are coin-shaped, 1 to 5 cm in diameter, itchy plaques. They are commonly distribute on the extremities and can become generalized. Acute lesions may be vesicular, chronic lesions may become scaly, characterized and confluent. Seborrheic dermatitis is characterized by distinct morphology, red, shape-like marginated lesion covered with grassy-looking scales and distinctive distribution, scalp, face, upper trunk, which are areas rich is sebaceous glands. Face, medial sides of the eyebrows, glabella, nasolabial folds, and predilected size. Blepharitis is a feature. Seborrheic eczema. Scab, dandruff is usually the earliest manifestations. In chronic cases, there may be hair loss, which is reversible when the inflammation is controlled. Os are the common site of involvement. Trunk. Petaloid form is commoner than the pityriaziform. Follicular papules with grassy scale that may become confluent and commonly found over the sternum and interscapular region. Follicular papules. Grassy scales that may become confluent and commonly found where sternum and interscapular regions. Seborrheic dermatitis infantile. The eruption in infants frequently first appear between the 3rd and 8th weeks of life. It may start at the napkin area, the face and scalp, and occasionally on the trunk outside the napkin area. The rash comprises well-defined areas of erythema and scaling with tiny vesicles. Papular and lichenificate lesions are not seen. Typically, the infantile is well and not irritable dermatitis. The prognosis is usually good. Irritant dermatitis can affect virtually anyone depending on the person's skin barrier function and the potential and duration of the irritant stimulus. Irritant dermatitis range from the mild erythema, the hemorrhagic bulla and necrosis after several episodes of irritation, and person is often at risk from allergic sensitization. Mechanical irritation accounts for the majority of unbalanced reaction due to planes exposure. Diagnostic features. The affected size characteristically conform to history of specific contact to suspective contents. Some non-exposed areas are also susceptible to irritant contact dermatitis, body folds, and flexure areas due to a combination of friction and direct contact with sweat of urine. Once exposed to irritant, improvement start to occur. Strong irritant contact dermatitis can occur after single brief exposure. The latent period is short. Examples are acid and alkaline burns. Thermal burns are frostbites. The offending irritant is usually obvious. Weak irritant contact dermatitis develops after multiple exposure. Latent period is long. Allergic dermatitis. The characteristic distribution of the lesions can often give a clue to particular allergen. Removal of suspected allergen leads to resolution of the dermatitis. A positive patch test to a suspected offending contact supports of clinical diagnosis. Both allergic contact dermatitis and irritant contact dermatitis bear similar clinical signs. In acute cases, weeping and crusting will be present, while in chronic cases, scarring and fissuring is the dominant finding. Sometimes allergic contact dermatitis, different from irritant contact dermatitis, its erythema and edema may be more prominent and pruritus more troublesome in the former. Acute allergic dermatitis is characterized by pruritic papules, and vesicles, on an erythematous base, like identificate pruritic plaques may manifest chronic allergic contact dermatitis. Occasionally, allergic contact dermatitis may affect the entire integument. Erythroderma, exfoliative dermatitis. The initial sites of the dermatitis often provide the best clue regarding of the potential cause of allergic contact dermatitis, Differential diagnosis, simple dermatitis, allergic dermatitis, eczema. Sensitization, simple, absent, allergic, monovalent, eczema, polyvalent. Time on development. Simple dermatitis, immediate, allergic from the few hours to 1-2 days, eczema, few days and more. Localization. Simple dermatitis, place of effect of irritant. Allergic dermatitis, place effect of irritant and outside its boundary. Eczema, different place of skin. Character of focus. Simple dermatitis, diffuse. Allergic dermatitis, diffuse with secondary elements. And eczema, combination of diffuse and distribute. Polymorphism, simple dermatitis not expressed, allergic dermatitis weakly expressed, and eczema expressed. Itching, simple dermatitis absent, usually burning and pain. Allergic dermatitis moderate, eczema intense. Progress, simple dermatitis not long, allergic dermatitis longer, and eczema long. Relapses, simple absent, allergic dermatitis rare, and eczema frequent because it's chronic inflammatory disease. Today finish our lecture. And continue next lecture. Goodbye.